Good morning, friends. David Wright here, and I am your host of the Disruptive Innovators, Champions of Digital Business podcast here, day after New Year's. Yeah, special day here. First podcast recording of 2026. I'm joined by my friend Oliver Galicki. Oliver, it's a pleasure to have you on.
Happy New Year. Likewise, David. I'm happy to be here and start the year together.
Yeah, I don't know why we hadn't done it sooner. I know we're just catching up off air about, knowing each other a little while now. We have the Chime connection, but Oliver, I know a lot of the folks in our community do know who you are, and we have a lot of mutual friends. But for any of our listeners who may not be familiar, do you mind just sharing a little bit about your current role?
Sure, absolutely. Currently, I serve as the Vice President of Clinical Solutions at Memorial Hermann Health System in Houston, Texas. We are a large IDN, 17 hospitals across the Houston Metro, roughly 35,000 employees today.
Yeah, no, 100%. I've been out there, beautiful facilities, renowned health system. So excited to learn more about Oliver. I know you guys have had a lot going on over the last few years. We've all seen it happening. So excited to dive into that. Before we do, I always like to start the episode with if there was just one piece of actionable advice you might look to leave the listeners with today, what would that be?
I think whether you're in technology or just interested in technology, I think the biggest thing, especially over the last couple of years of change that we've had, is get your hands on the technology, see where the technology is meeting with clinical and business operations, whether that's in an office or on the clinical floor. I think that is the most important thing today because of the amount of time we spend implementing technology, selecting technology. How is it actually working? What does it really mean to the users? What do they really need? I think that's really the most important thing we can do in the chaos of kind of the day-to-day health IT demand.
Yeah, it's great advice. Great way to start the episode. And I think in healthcare in particular, my experience has been that classically, as digital stewards in healthcare, we may have been more trepidatious about bringing in technology to the environment because fear of security or fear of, these are people's lives, right?
Right.
But we're at a crossroads right now in healthcare, right? Like with, I'll never forget these like CEO things we have at Chime every year where they go over like the state of healthcare and like the shortage of like physicians that's impending and like baby boomers retiring and the nursing and all of it, right?
Yeah.
We're going to need to do more with less. We're going to need to continue to improve the experience of patients, improve the experience of our colleagues. And to do so, we need to disrupt, right? And innovation requires movement and courage, right? And I think the more that, to your point, you can put something in front of someone so that they can familiarize themselves with it and touch it and feel it and say, oh, you know what? This could be great for that use case, and get them in. I think it serves on a number of different levels, like the education, the understanding, the change management element of it. So yeah.
Yeah, I think it's that element of overall partnership that IT is a partner to all of the different pillars. And I know different organizations call IT many different things, IT, IS, digital, whatever that technology arm of the organization is, having that be viewed as a partner is very different than traditional. And I joke about this, that I think 16 or 17 years ago, my first job in this field was really when we started talking about patient health records online and how do you just access results. And we talked about being just like banking and being behind banking. How do we get there? And then
Right.
sure enough, today we still talk about how can we be more like banking? And I don't know that we always need to be just like banking.
Right.
Transactional, yes, money is important. I think it's probably secondary to your health and how that impacts your family. But it's the same talk track to your point of there's headwinds, there's less with more. In the nonprofit healthcare system world, that's not changing. But partnership is what can lead to better adoption and more return on the investments that we're all making out there.
Right. 100%. Um, I think that's a good transition. I mean, you mentioned, 16, 17 years ago. I do, before we get into some of the work that you guys are doing at the Memorial Hermann, want to hear the, you know, Oliver origin story. So maybe we could start with just kind of how you started out and how you got to the point that you're at in your career today.
Yeah, absolutely. I think, like many people, I don't know that I knew exactly what I was going to do when I started college. I knew I had some interest in business. I had some interest in technology. I thought maybe I wanted to be a physician for a point in time. And so, really, all that being said, I was a very still probably am would be a type A individual. I had a lot of different plans. I would read the college catalog and look at all the different tracks I could go if I did certain classes and whatnot. But I started down the general, freshman year. You start taking different classes, and I stumbled into a computer science class, and I thought, oh, I like this. I like the logic. I like the programming. I don't necessarily feel like I fit in with I don't think I would be a developer. I don't feel like that was my personality, that I'm going to go and develop gaming software or go into that. I thought there has to be something to this that I could use these skills and interweave that with something in business. So that was what I knew freshman year of college, going through that computer science class, knowing I wanted to take the next level. I took an internship that I really didn't know a whole lot about. It was with a physician hospital organization, Mississippi Health Partners. It was 50% owned by two competing hospitals and 50% owned by independent physician groups in the Jackson, Mississippi area. I knew absolutely nothing about that business. Some of their core business was repricing claims as a third party administrator. Not super exciting stuff, not to toss water on that industry, but that wasn't necessarily what caught my eye. It was really the CEO was working to figure out through a new offering how they could diversify what they did, and was starting to dabble in the patient health record space. And so Mississippi Health Partners Connect, was a branded relay health information exchange that we started to create and market in our local Jackson, Mississippi area with our physicians, and then with the two competing hospitals that jointly owned that. Again, I was just a sponge, and I was learning this while also I was coordinating our office move from one location to the other. So that was my intern duty. That was really just following the CEO's lead and learning and absorbing that. And I always say it was one of those chance encounters. I happened to get to know the CIO at one of the health systems. Keith Van Camp was the St. Dominic's CIO at the time. And I thought, wow, that's cool. They do a lot at the hospital. That's not just this. This is one little part that we're talking to them about. And we're trying to be just like banking, where someone can see their lab results online. And I probably, as an 18, 19-year-old, didn't even have lab results that I could really go and check. Like, none of this was super familiar to me, but it sounded like reasonable that I want to do everything online. I want to register for classes. I want to order books. So why wouldn't I want to do this? So that kept me going, and, went back to school after that summer, actually worked another summer as an intern at this organization, and then made an outreach to Keith, the CIO, and said, I'd like to come and be an intern at St. Dominic. And so I could tell, based on the introduction and connection he made with his team, it was one of those things where CIO likes this guy, met him as a summer intern, and it's kind of like, hey, here you go, find something for him to do.
Figure out something for him to do.
Yeah. And they knew nothing about me, but we did an interview, and I started mid-year as an intern at St. Dominic in the middle of my college career. And it was what you would expect, was what can you do? What are you learning? I was a committed computer science major at the time, also taking my business classes. So had evolved there a little bit. And my first project at St. Dominic was to go around to several thousand laptops and plug in a thumb drive and upgrade the SSID and change it over to the new wireless network. And I fell in love with healthcare really from that moment forward, because I got to go out and be in every single place in this hospital system. I think it was 500 beds or so in Jackson. This is one of the bigger healthcare systems in Jackson. And everywhere from behavioral health to cancer center to environmental services, materials management, all the nursing units. And I got to see it all. And I just thought, this is amazing. There's so much in this one campus of activity. It's not just programming. It's not just fixing computers. It's everything. And that was the light bulb that went off to say, healthcare is for me. Technology is my way into healthcare, but this is the right industry for me. And that really hasn't changed at all in the last 15 years or so. Um, so I, that was the lighting bulb. I did not continue to just do that. I think as you get to know someone and work into the relationship, I started doing some programming work with them, and ultimately became an HL7 interface programmer. I sort of worked my way in. We had Cloverleaf, and again, it was that light bulb of, oh, I can program and I can talk to a vendor putting in a dietary system. How do we connect that with our McKesson series mainframe registration system and all of that in between? And again, just the connectivity of the healthcare ecosystem and the stakeholder involvement was what kept me going. Interestingly enough, I was a football player in college, and I had an injury after my junior year where I couldn't play my senior year. So I'd like to think everything aligned where someone left the organization, they had an opening. I had a lot more time on my hands, was almost done with all of my schoolwork, a little bit ahead of schedule. And so I was able to start full time while I was still an undergrad and really commit time to that. And that was my kind of shifting my passion from the football field into this healthcare IT. And honestly, what would carry me forward? I was the Division III football player, so going nowhere from a financial perspective in part of my life. But so this was really it, and I stayed pretty committed to that from that point forward as an interface analyst for several years at St. Dominic. So that was how I started in the field. I definitely dabbled with, do I want to be a doctor? Do I want to do this? Do I want to do this? But it's always drawn me back to, I can make such an impact in this space, and it's so important to support the clinicians and the health systems at large that it never was, let me go take organic chemistry and actually take that final hump to go do medical school, just because this fell in and was such a passion for me.
Yeah. No, I get it, because I mean, it was not, it was similar for me. Like I would say it was more recent. I really started working in healthcare in earnest, like in the last like 6 years, where now like I would say like 90% of the work that we do is in healthcare. But I had worked with health systems up until then, but when I really saw the impact our experience could have on a health system and the care that patients receive and the experience that they have, and just playing a small part in that, right? I'm not a delusional, but that was exciting to me, right? And to your point too, you visit these campuses. Like I'll never forget the first time I visited St. Jude. Keith Perry had me out, and just touring that campus, and like it was a lecture, like it was just the things that they were doing, just really really exciting. So um a follow-up question, right, would be um and how long have you been in Texas?
I've been in Texas since 21. So moved to Houston in 2021 for my first position at Memorial Hermann.
Got it. So over the course of your journey, either in more recent years or, prior to getting to Memorial, what would you say is one of the most important things you learned um, along the way?
Yeah, I would say I'll probably tie it a little bit back to what I opened with earlier in the show. I spent about 7 years at a community hospital outside of New Orleans, in between Houston and Jackson. And as the applications manager and then the IT director over the entire operation there at a community hospital level, so 220 beds, outpatient clinic, outpatient imaging, you get involved in everything, and you have to learn the business in order to be successful in that role. You cannot just be a 35-person IT shop and not be very involved. You can't be just sitting there waiting on someone to tell you what to do. You need to be very blended with operations to help them what they need to do, whether that's building new dashboards to run a bed huddle or custom developing a solution because you don't have the funding to do something different. That problem solving and engagement that I had during my time at Slidell Memorial was incredibly important to how I lead and to how I would expect my teams to be out there, to be partner, to listen, to field requests and solve problems and try to not be the face of no that IT often is. And sometimes it's protect an organization, but other times it's should be no, but how about this or this or this, or can we think about this? And so that experience really bundled all together that my time at the community hospital was honestly something that I didn't know I'd be able to leave. I didn't know that I wanted to move into a larger IDN and be pulled away from some of that because you're so close to walking across the street and talking to the CFO, just very casually there. And I didn't know that was the same thing that would happen as I moved into larger organizations. But it's something, those lessons are something I take forward and I remember and think back to constantly in my role today.
Yeah, it's interesting because I think they're just as relevant with a large health system. I think it can be more challenging, right? When you add more people, you add more politics, you add more
Academic, I think that comes into it.
What was the last thing?
The academic relationships that sometimes
Right.
come with larger health systems, that's challenging.
Exactly. More M&A. So all of it, I think, makes it more complex or complicated, but the just as relevant, if not more relevant, or I guess it's all, relatable, but,
It's scale. Yeah, it's same. It's very similar, but the scale changes, obviously, maybe some of the complexity.
yeah, and it's interesting because what you got me thinking about was I think there's the kind of, engagement, enrollment, and, you know, fulfillment for different operational groups across a health system. And then, it reminded me of this academic health system we worked with, like, I don't know, a few years back. There was an imaging latency issue where, basically just that, like, they would take an MRI, they would take a CAT scan, whatever it was, and it would just get caught in the ether and like not get to where, a doctor could view it in a timely manner, to in layman's terms, right? And then what our experience was, because like people were like, oh, it's probably like the bandwidth, or oh, it's probably this.
Network, yeah.
It was like death by 1,000 cuts. There was like literally like I think 70 different recommendations that we had leading out of it. And to your point, what it took, I actually brought in a CIO buddy of mine who had that kind of broad experience where he had worked with all these different groups and worked in different areas of IT as well, such that like maybe he wasn't like CISO level security expert, but he knew enough to host those conversations and get those people thinking. And he knew enough about network and he knew enough about clinical applications, and he kind of ran across the stack because one of the things that he saw happening even within IT as a, group supporting a health system was that there was silos within IT such that like people were only concerned with like doing what they were responsible for and doing it really well, but they weren't concerned or as, aware of how it was connecting with the rest of it, such that a lot of the breakdown was in the in between, and or the lack of understanding of how it was playing with everything else. And
And
yeah, so I think your point to me really resonates because I think it's applicable to the operational groups and then even like within IT itself.
it's painful when you see it, and it happens. It happens today and now. It pops up every now and then, but and I think the IT leader that has the ability to say, I know enough within my own IT realm to hold my own teams accountable to say, like, guys, this doesn't make sense. We don't like, and I say this sometimes, we don't like when X department points us to X department within their team, within the same team. We don't like that. You don't want to call HR and be told to call this other division in HR. why would we do that to someone else? And I'm not saying our HR does that here, just an example, but I, it's the same concept. So if you know enough and you have the breadth of IT knowledge, you can hold your own teams accountable. You can hold your vendor partners accountable. And ultimately, you create a better face for the operations and clinical side of things. I think at the same time, you have to build that credibility over here to say, I can help think of ideas that are not related to IT, but to say, have we thought about contracting like this way for this service? It might have nothing to do with me, but I'm involved in that conversation because there's an IT part. How do I become seen, and not me personally, but I, as in the IT organization, be seen differently to say, yes, I have ideas just from, I do contracts all day, every day. It's not my favorite part of my job, but I can help with ideas in that space over here. So it's all about creating that partnership at the end of the day. But 100% agree. It's painful to see, and it's easy to call that out when you've seen it work other places where there can't be silos. You're not big enough to have silos at a 30-person IT department necessarily. So you have to quickly get those, remove those. And so when you've seen that work, it doesn't matter if you're 600, 700 people, you know it's possible, and you can push that kind of partnership, one team mantra.
Right. Yeah. Gene Kim and I would talk about like, how are we flattening out the health system? Right. Because otherwise, if you have these situations where things go up and down and up, and it's just a
Yeah.
complete waste of
It is.
time and resources. What about a time that you either had, because as IT stewards, we've all had projects fail, right? But either like a project that stood out in your mind, or a time that you just had a hardship personally, professionally, or otherwise, but ultimately you took away a lesson, a profound lesson, or a perspective shift. My experience has been that I've always learned more from the difficult times in my life uh, than when I was winning, right? Like I can
Right.
point to a lot of the most profound shifts I've had in those moments. Is there one that sticks out in your mind that you might be able to share?
Yeah, there's probably, I'll do two, try to be brief. One was an early career as a hands-on analyst, and I've taken some steps. I've learned a lot from that experience. And then more recently, I have an example as well, just to draw the difference. But in that first position, when I was a HL7 programmer, cloverleaf analyst at the hospital, Mississippi, um, I was tasked with our Cloverleaf upgrade. So we had a whole new this was all physical, all on-prem at the time. Physical server. We were actually repurposing an old full blade from one of our hosts that we no longer needed for our EHR, and we were going to use that as our new platform for Red Hat to move our Cloverleaf instance over to it. And I architected the whole thing in my head. I documented what I knew to document, but this is probably, a 20-year-old architecting this Cloverleaf upgrade, several hundred interfaces, and we tested it. We did the whole thing. I obviously had support from my team in terms of, we had Red Hat engineers and we had another interface analyst, but I had never had a project fail before. I had never had a project that encountered challenges to that degree. We had done EHR upgrades, and it was an EHR system that had a lot of challenges, but it wasn't my project from soup to nuts, that this was my thing.
Right.
And so everything, of course, went great in testing. We were able to move our test Cloverleaf over to the new instance. Then it came to go live night, and we followed the script. We turned everything down. We started bringing interfaces back up, and a random 1/3 of the interfaces wouldn't come back up and connect. And if you brought them all back down and brought them all up, it was a different 1/3 that would work or wouldn't work. So it wasn't the same interfaces over and over again. And I ended up with my team working all night trying to figure this problem out. Well, we were very frugal, I would say, and did not have the highest level of support engaged from our vendor at the time on standby, because we were doing this ourselves. We weren't going to pay. We didn't have the budget to pay for support. So this was, of course, a Friday night doing this up, Friday or Saturday night doing the upgrade. There was no reinforcements coming. It was all of us just really hammering this out. And so after being up for 18 plus hours, we still had interfaces that were down, and we were basically turning the interfaces down and back up to let interfaces clear, but things were getting out of sequence in the clinical systems. And I was, that was my first probably true IT panic meltdown for myself, where I was like, what do I do? I
Right.
had left, I had not built out it was a team of 2 interface analysts. So we were both up all the time. I was the primary on this project. And so I would go at home and I slept for a little while. Ultimately, this ended up being some sort of obscure Red Hat kernel level setting that needed to be updated to allow for the volume that we had to connect and transact.
Fucking Red Hat.
Yeah, and so just something that small, but I, felt the weight of the world on my shoulders. So what I've learned from that was planning, having the dual. You can't just have, like, how do you resource a project? I've never, with a small team, we shouldn't have both been there the whole time with our manager. We were all up all the time. The vendor support aspect, yes, there's financial challenges. We might want to do a project ourselves, but always letting a vendor know you're doing something so they're available if you need them, and not just expecting them to come in and save the day. I learned a lot from that early in my career, and that feeling I had when I was driving home and it still wasn't working, but I had to go sleep for a little while to come back and try to help solve the problem, um, was a terrible feeling. And I've tried to not let my teams be in that position moving forward by thinking through a little bit more of the reality.
Yeah. No, that's a great, I've had so many too, right? We all
Yes,
have. And that was a Cloverleaf upgrade?
that was a Cloverleaf. Well, it was really a replatforming of Cloverleaf to
Right.
get
So,
it
yeah.
to then be able to upgrade it. Yeah.
And it's interesting, right? Because I think you made a lot of great points about like looking back, like how would I have done that differently? Another thing that it brings up for me, right, is the value in what we get through like Chime or just like coming together as colleagues in the healthcare industry is that I guarantee at that point in time, there was a healthcare organization that had replatformed Cloverleaf and that had gone through that upgrade.
No.
So they had that experience. And I was having a great conversation with, the CTO, CMO at the University of Colorado Health not too long ago. And we were talking about like, if someone has solved this problem already that I have, let me not go figure out how to solve this problem again. Like, let me just borrow how they solved the problem.
Right.
Now that requires me, A, being willing and B, actually reaching out to those people and developing those relationships, of course. But my experience is that like 80-90% of the time, people are willing to have those conversations. Now, maybe if it's your like health system next door and there's like a little bit of competition there, it can get a little bit more, you know. But
Yeah.
but even like I'm a or a HIMSS fellow in the Atlanta and Ohio, Northern Ohio communities, everybody's very collaborative.
Yeah.
Everybody's very collaborative. So
I've found on the IT side, we've done a few events recently as a Houston, Texas Medical Center community, and yes, we all compete, whether it's on a oncology service line or orthopedic. I mean, there's tons of competition in this market. It's one of the most competitive healthcare markets, but I found generally, especially now that we've all aligned on the Epic platform from a core Texas Medical Center like we're not going to compete over a core Epic functionality that we all have. And so we're troubleshooting that. That's not a competitive advantage. We all have that platform. It's really, how do you innovate on top of that, and what services clinically do you offer? All of that is sure, but at the core, hey, how did you do your Workday install, or something like that? I found the collaboration to be there, and I agree 100%. It's usually uh, it's the connecting that needs to happen. I think everyone's very willing, and even if the answer is no, we did not use Spoke as our middleware. We used XYZ as our middleware for this clinical communication tool. It's like, okay, well, I will still answer that and say, no, we didn't, but there's probably some parallels towards pain points, regardless of what you do sometimes, that happy to help with. And that's been a great, I know we jumping ahead a little bit of this post-Epic experience for me is we, Memorial Hermann, were certainly on the tail end of large IDNs. This wasn't necessarily, I think you saw a ton of activity over the last few years, over the, I would say late half of the 2010s. And then we did our implementation starting in 2022. So a lot of lessons we could learn from others. But then there have been a number of other systems that we're also making, typically in Oracle Cerner transition to Epic, that we started to field reference calls for. And it's been an investment of time, certainly, but I feel like people did that for me. And so it's been fun to do that for other people and trying to be helpful and give them different ideas or watch out for this, or here was the reality of this. That's been a valuable experience. And no one's ever said no. And I don't think I've ever said no to doing that for someone else.
Well, I think that's the you know, in my industry, like as an advisor, um, I'm on the board of channel partners, and I'll go and I'll speak in Vegas or do these
Mhm.
other events where I'll share our experience and our frameworks for consulting in healthcare. And like some people will be like, well, David, you're like sharing your secret sauce or like whatever. And the truth is, it took me like 8 years to build this, right? Like if you're gonna hear what I say and build it like on a dime like that, like you deserve that.
Right.
Like you're a brilliant person, and like God bless you. I'll see you out on the battlefield. But otherwise, like I want to share my experience to help others get better and be successful, because there's enough, right? Like I believe that like from an abundance mindset, there's enough
Yeah.
for everyone.
And I think in this community, I mean, you've mentioned several different organizations where we all connect. I think the reality is none with the way the industry is going, it really has been going. You never know when all of a sudden you might be across the country, but all of a sudden you're in a merge with someone else, or
That's
there's
true
a lot
too.
of dynamics. So just from a how would I want my team and myself to be portrayed if we were in a relationship or if we were to move organizations, like all of that is just again we're all of us are trying to take care of patients. Yes, we're all trying to win the competitions in our local markets and be number one in quality and number one in volume and market share. But at the end of the day, we all have a very similar mission, and most people in healthcare IT that I've encountered bring things back to the mission pretty quickly. It's not if you wanted to be in financial services and do financial services work, you probably wouldn't just choose to be in healthcare if that was your passion. So I think it's finding that as well.
No, for sure. So you brought up kind of tangential of the work you guys were doing at Memorial Hermann. So I want to get into that with the time we have left. Before we do, I do always like to throw out their favorite book that you've read recently or all time. I know we were kind of talking about this pre-episode. So what do you got for me?
Yeah, lately, lately I've been fascinated. So it's not a book that I've been reading for myself, although it's a book I read when I was younger. My almost 4 year old has become pretty obsessed with the I Spy books, the big version of the I Spy. We did Halloween, and now we have the Christmas one, and I've been challenged with as we read them at night. Usually it's a procrastination tactic on him to just do one more page, but we read every single line and we find the seven cookies and the six this or the obscure this. And I have no magical parallel to draw that to my work, other than I have found it just as challenging as he has at times to find these, and just as frustrating when we can't find just that one thing. Sure, I could draw a parallel to things we do every day in healthcare IT or healthcare in general. But I read those books as a child. My wife read those books as a child, or I say read. We did those activities in the books as a child. And to see my 3 or 4 year old just get fascinated and hooked on them has been fun. And it's again, it feels good when you find the whole page and you can move on to the next one. So that's been a lot lately. I don't know what we'll do after Christmas now that that's over, but there's like 7 more books we'll work through, I'm sure.
Love that. As the quick aside, I brought back like the Peter Rabbit series
Yeah.
from the UK because that was a book that I read as a child. And like so we have a bunch of the stories, Beatrix Potter, and it's funny because like the like there's parts where like the one of the like mom rabbits like beats the kid with a stick, and like they're smoking rabbit tobacco, and like he dated. So like I've had to find myself like censoring stuff from
Yeah.
Peter Rabbit book.
It's funny you say that. There was a book recently where my son was like, "What's that?" And one of the, I think maybe it was a pipe, like a tobacco pipe,
Right.
but that's a pipe. I was like, "I don't know what to say." I did, um, maybe not cat of the year, I don't know.
Yeah. Anyway, so you've been at Memorial Herman now. It's been 4 or 5 years, right?
Yep.
Give or take. Um, I know personally you've been promoted a few times, so you're VP clinical applications now. Talk to me a little bit about your vision or your team's vision for the organization that's derived from the overall mission and maybe some of the key things that you guys have been working on lately.
Sure, sure. So yes, it's been almost 5 years in a couple months. Next month, maybe it will be 5 years here at Memorial Herman. I originally came as our lab, rad, and pharmacy applications director in that space. Moved into a role to lead the Epic implementation across the enterprise from 22 to 24, and then recently, last year or so, I've been in this new role. My scope is not 100% of our clinical applications. I spend most of my time in our procedural and diagnostic areas of imaging, radiology, perioperative space, anesthesia. I have our integration team and our overall Epic environment program team, and our clinical engineering partnership relationship with our, we call it our, excuse me, we call it our clinical technologies team. So how do we align with our clinical engineering arm of the organization? And what's been most pressing for my team coming out of the Epic project? Yes, Epic as a whole, there's optimizations. I think everyone who's been through it is optimistic that a year is going to feel like everything's in a great place. I think the platform is very stable, but the optimization volume is huge, and that spans all teams. I think it probably hits our core clinical teams, ambulatory, inpatient, the most. But in our procedural areas, we still have challenging Epic workflows or places where we could do better and do more optimization work. So that's way more than a 1 year stabilization effort. That's really probably a 2 or so from other peers that I've talked to in terms of where we will feel like we're back to where we were, that we had a handle on all the optimization requests coming in. In the imaging space, particularly, I've seen that as our new frontier of optimization that we have to work through at Memorial Hermann. So it was not the most stable and clean environment before Epic. We put a lot of things on pause for the Epic project. We did enhance some of our imaging workflows through Epic and moved a lot of our workload into Epic. So we do radiology work listing inside of Epic. We do cardiology structured reporting inside of Epic, and made our peripheral imaging systems and packs less of a workflow engine, more to support the imaging side, less to do what we thought Epic could do better and put out more development on. But we still have segmented packs. We have cardiology packs. We have radiology packs. We have a VNA that we're not fully leveraging. And so we've made the investment in Epic as an organization. We've made, and in parallel, we're doing an ERP implementation right now and been redoing everything from an HR, supply chain, and finance perspective. I see this, and I've seen other organizations do this too, as the other third large investment that we must make to really to consolidate and streamline and stabilize those environments. And so that's what we've been working on, an Enterprise Imaging 2.0, super creative name, project over the last 6 or so months, and bringing stakeholders in from the traditional radiology, cardiology, but also trying to get our service lines that use imaging a lot involved in this effort. And, I don't want to say it's all been AI driven. Obviously, AI is a part of that conversation. But at the end of the day, providing reliable, timely, stable imaging services is at the core of delivering care, period. You really don't enter the health system and not touch imaging in some way. It's very, very rare you're not getting a chest x-ray at a minimum. If you're an inpatient, you're seeing seeing a primary care doctor and you have a complaint, or a specialist, you're getting imaging. So at its core, that's really the foundation of this effort. If we want to do business and be a top level, we have to have access to our images. We have to have stable platforms to deliver those, and we need the most up-to-date clinical tools, which may include AI, but some don't even include AI. They've been around forever, but they're just not what we have today. We need to deliver that to our customers, and then factor in disaster recovery, resiliency from a business perspective into this project. So we're moving forward with that effort. And as we start this fiscal year, we haven't selected a final direction yet of a platform, but we are looking at the end of the day to consolidate our imaging platforms And so I would say just like we have an Epic first, but not Epic only strategy as a core EHR, we'll have an imaging platform that we build on and say this is the platform that should serve most of our needs, and then we would integrate as needed from there.
Right. Uh, Just pause for a second. Are you up on time? Do you have a meeting right now?
No, I don't have anything till 10:30.
All right, let me just
Sorry, I've rambled.
no, no, not at all. We kind of started a little late. Hey, can you just tell them I'm running like 10 minutes late? Thanks. Um, no, yeah, I'll pick it up for. No, no, 100%. So guys, start here. No, no, 100%. And it brings me back to the comment I had made earlier about the imaging latency assessment we had done. Even them, they thought they had 3 or 4 packs and CPAC systems. It turns out they had like 7.
Yeah.
There's like other things going on. So, and like imaging is also one of the, biggest revenue drivers for a health system, right? As
Yeah.
we know too. So
Yeah. It's a revenue driver. But yes, imaging systems percolate out there in the organization. Even if you don't consider it an imaging system, you realize a workflow has been storing on a server for 5, 6 years. You usually find it when you do a Windows 11 update and you got to update the software and you're like, oh, where does this image get stored? Oh, just over here. No one else can see it. Just that one department. Is it useful then to anyone? No. Okay. How do we fix that?
I got a funny report I'll send you after this, but I digress. So you guys got a lot going on. Clearly, what are some of the biggest challenges you guys are facing as an organization?
I think the reimbursement, regulatory pressure, the financial headwinds is kind of the industry term I've been hearing a lot of lately. We are certainly feeling that at Memorial Hermann, as I think most nonprofit health systems are feeling or have felt. I think we have weathered fairly well. Our senior leadership team does a very good pragmatic evaluation of challenges, and we tend to not overreact or underreact. I think the goal is to be just right. But so we certainly feel that, and we talk about that as a leadership team, which translates to what I tell our team is that we need to be able to articulate when we say we don't have resources to do X, Y, and Z right now. We need to be able to have the conversation with the business to help them prioritize. Like we need to help them identify which actually has the higher return on investment, and whether that's a clinical need or just financial to say, hey, signing up for this subscription service for X, Y, and Z, we can do this and the implementation will take us this long. But don't forget, we've had these things on the list, and could they actually bring more immediate value, whether that's in reducing, staff overtime because it's more efficient? Is it just implementing some native Epic AI features that could help relieve a certain problem as opposed to something else? I think we have to be stewards of that. And we in our department, our CIO has always done a very good job from a financial navigation perspective with that. But we are engaged with that. And I think it's even more important now as we're feeling that kind of pressure.
100%. It also and also quantifiable risk, right? Like there's the ROI, then there's some things that like might not have as significant an ROI, but if I don't do them, they could lead to this, right?
Correct. And our imaging project was frankly a big example of that. I've been able to show, yes, by consolidating platforms over time, we will have decreased IT spend, which is a positive. We will consolidate these applications, but it's not comparable to opening up a new service line and bringing in new revenue to the organization. It's a savings, and you have to spend money to achieve that savings. And so that being said, I know some of our vulnerabilities that exist from a platform perspective today that, if we were not able to provide imaging services because we had a sustained downtime, that's quantifiable. So working with operational partners to tell that story, it's not a pleasant story to tell, but it's reality until you get into a hybrid cloud model or fully cloud model where you can be more resilient. But that's not where we sit today. So yes, that storytelling is very important in our role for sure.
I think, I have one last question for you. Like storytelling in general, I think is an overlooked talent by a lot of IT professionals. I think it's if you can storyboard out kind of and really help people visualize why things make sense and tell that story. It's just I think it's a lost art for a lot of folks. So I'm glad that you guys are a proponent of that. So Oliver, a couple last questions. One would be, what do you think will be some of the biggest changes in the healthcare industry as time passes? No, acknowledging you don't have a crystal ball, but just like, maybe some of the more macro trends or things that you're seeing that are exciting, anything like that.
I think I don't know that I'm seeing this yet. I've heard chatter about it, but I think at some point we're going to have to find a way out of the pilotitis, the over piloting, and the we're going to have to actually pilot things and turn them off, and pilot things and scale at a more rapid pace, or not even use that word anymore and figure that. I think the demands on the IT organization and healthcare. So if you take all of this together, you say the margins are tight. We need to spend less money on professional services potentially. We need to make sure we're getting the most value out of the resources that we have. It's
Yep.
hard to say we can keep incrementally adding projects that are um, that have potential, but you add 10 at the same time, you can't do them all. And if you're doing them all, you're giving them all 100% attention that they need. So I think there's some reckoning that has to come, at least from a how do organizations prioritize demand and initiatives. And it's not that we shouldn't do them; it's that we need to make sure we're working on the right things for the right reasons across the spectrum, whether that's an IT project or not an IT project. I think that's just
Right.
investment in general. From an industry perspective, I do think that will some point, a lot of this hints at the AI world. Where are we going with that? I think the more that core vendors ship features with their core platforms and they can be enabled, that's great. There are some workflows where I'm all about safe use of AI, but the human in the loop is going to become a barrier to adopting a solution on some of these workflows. Where if you're going to make a human look at it, some humans will say, well, if I'm going to look at all of these anyway, what's the point? Like, what are we, if we're going to generate 500 denial letters and I'm going to skim 500 denial letters, A, is the person really going to do it? B, what's the value? So I think there's going to be a shift at some point to say, I guarantee you that my cable provider is just sending the letter out that AI generates. Like that they're not reading every letter it's sending out to say that, you're over your consumption of something. So I think we're going to have a shift in some of that if we're going to actually take advantage of this, or the spend on AI will not take off like it seems to be right now. I think that's something that we have to reckon with the risk and benefit and where is this safe to move on. And I think there's some good industry collaboration happening in that space to sort of set those framework. But there's the reality. I think as long as it's not too academic, it needs to bring it back to reality to say like the value of this technology is X.
Right.
And if you don't achieve these results, then why would you pay for X just because it's AI? And I think another trend that I'm watching is we're very focused as an organization on the community and a shift to the value-based care model across the patients that we serve, working with employers, et cetera. I still think at the end of the day, we have a heavy brick and mortar presence across the Houston metro area. We still see growth in the Houston metro area. So I think for me, I'm just watching this shift of we've been talking about value-based care a long time. Since my entire career, there's been that shift to value. I think it's certainly closer than it's ever been. There's real contracts that are risk-bearing out there, but I think from an IT perspective, it's almost like supporting two different but shared missions. There's this, we still are growing our hospitals and growing our physical footprints and building towers, and there's technology required there. And then there's this new, more analytical, data-driven mindset required to support the value-based initiatives, which ultimately might push people back into the brick and mortar, but you have to support both. And as IT leaders, I think we know less about that value-based model that's being developed and matured than we all do, because I've literally walked the halls and touched modalities and been hands-on with these things, and this is a little bit more nebulous. So from an IT perspective, we have to evolve to meet that as a health system and not just rely on external partners to do that forever. We have to have that. We have to have some of that internal knowledge to do that well.
Yeah. Uh, wow. I love that you brought that up at the end. I feel like I could have a whole nother podcast episode about value-based care. And like we were talking about, I got back from the UK, like we're working on these integrated neighborhood teams, which are like similar, but
It all
anyway,
gets into how it's paid for. I think at the end of it, like that's the challenging part. Like I know through our innovation hub that one of my peers is responsible for leading. One of our campuses started a community paramedicine program at local to their campus, and it's all about preventing those folks from coming back in and getting readmitted. It's not about billing for the services they're going to do, and that's just this American system is just not how it's done. So I think even at that micro level, it's very hard to then say, yeah, we'd love to do that everywhere, but how do you pay for it? And how do
yeah,
you
you gotta
actually go that
incentives
route?
need to change, and there's other
Yeah,
things that
yeah.
with insurance need to change. It's very it's complex, and it's complex everywhere. But it's great to hear that you guys are in the question and working on it. Oliver, this has been great. Last question I just have: if you were to go back 5, 10, 15 years in time, what advice would you give your younger self?
Oh, that's a good question. I think I would really give myself the advice to find a way to keep that community hospital alignment that I talked about with operations. I think I've rediscovered it recently. I probably lost touch of that some as I moved into the larger systems. But to go back, I would say don't stop doing what made you love working in the community hospital environment, which was very hands-on, as needed as a leader, and just carry that forward and be more intentional about driving that forward as you go into larger systems. So for me, that would have, I would say over the last year and a half, and maybe some of the Epic project, I've been able to do that. But you tend to get into a corporate department, and it's easy to just lose that. And so I
Right.
think if I would have said, never lose that, be there 100% of the time when you could be present, especially through this remote hybrid world. I would tell myself that, just double down on that message.
I think it's something that we all need to be reminded of continuously. So great way to end. Oliver, this has been great. Thank you so much for taking the time today.
Absolutely. Happy New Year, David. Thank you.
You too, man. And to our listeners, thank you all for tuning in. We will catch you all next week.